All right, good morning, everyone. Why don't we go ahead and get started? We're very excited to be presenting from Exhaustion to Empowerment, a survival toolkit for reducing care team burnout. Let me just introduce our team of who you'll be seeing today. We'll have a presentation by Noel Dillon, Felix Kraus, myself, Jennifer Bowers, and Kevin Lampy. And here's the big question. Who is Dedalus? Many people in the United States or North America aren't familiar yet with Dedalus, but we are a company that's been around for over 40 years. We're in over 40 countries. KLAS has said that we're one of the top 3 pure global healthcare software companies. We are in 6,700 organizations. We spend 38% in research and development. So we're very involved in innovation and always making sure we have the most innovative tools. And I think most importantly, the data of 540 plus million lives flows through our software every day. So today we're going to talk about a little bit about burnout and how some of our tools can help manage that. So just a little bit about burnout. And just so everybody knows, my background is I am a nurse. I was a clinical oncology research nurse for many years, so I can tell you a lot about burnout. About 50% of a clinician's time is allocated to administrative tasks instead of to patient care. So our goal is to decrease the amount of time spent in administrative tasks. 50 terabytes of data. Hospitals generate more than twice the amount of data and paper than the Library of Congress. That's a big one. 47 year-on-year increase in documentation in hospitals. So every time there's more regulations, there's more documentation that has to be done, more time spent doing that documentation. And I think the biggest one, there's a 95% increase in the odds of making a medical error when a clinician is experiencing burnout. So that's why we really have to work on this problem. We're going to start with Noel talking about our front door to care. Noel, you're on mute.
So I'll just say good morning again, and thanks very much for your time this morning. The subject is burnout, and I think what we really need to look at is where does that come from, and is it realistic to try and technology add a solution to solve that problem? And I personally believe it is. Experience tells me it is. And that's what I'd like to go through with you now this morning. But where does it come from typically? It's going to come effectively from paperwork. It's going to come from spreadsheets and arguing over who has the most up-to-date spreadsheet. It's going to come from the phone that never stops ringing. So how do we begin to run a business where we're not all going to have fun playing around with who's got the best spreadsheet? How do we limit the amount of paper we have when there's an amount of regulation that needs to be followed? So what I'm going to do in a very brief amount of time is give you an indication of just how that might be achieved using one of Dedalus's products, and that product is called SwiftQueue, for which I'm the I'm the sales director for the company. Sorry, would you just go back for a quick second, and I will fly through the rest of it. The digital front door is made up really for us of 2 access points. One, have we got an appointment that can be determined as an on-demand appointment? I have capacity, I have clinic capacity, and basically it's not necessarily time dependent on when somebody attends it. And so effectively I turn up. It would have been a walk-in type service in many clinics many years ago, but the idea is now that we get a patient to go online, either they qualify for a slot, self-referral portal, which we provide, or it's a direct booking into the available slot because you're accepting all comers. And that would be for things like vaccination clinics, STI clinics, phlebotomy clinics. The other one is a bit more tricky at times, where a referral might be needed and we need proof of the referral, or we need some other level of qualification. In the public service side of it, this is a huge element because it gives rise to a waiting list. There is ideally there is no waiting in private hospitals, but of course, whether that's a couple of days or longer will depend on how competitive you are and how efficient you are, and we're looking to make people as efficient as possible. So effectively, we got 2 levels of access into the system. If we move to the next one, Marguerite, thank you so much. So in essence, what we're doing is we're managing either the patient directly booking through a self-referral, or we're receiving a self-referral from a consultant or a GP. We're allowing that booking to be made online, or it's a back booking depending on how the clinic is run. We manage that patient flow. We manage the patient flow similar, in fairness, to the patient flow you'd be expecting on an EMR. But our role is different. We're looking outside the hospital. And in looking outside the hospital, what we're looking to do is deal with the patient electronically, get safety forms filled for radiology, get consent forms filled for things we need consent for, any pre-op instructions, and also financial validation. Because of the way we set this up, we can look at load balancing across the entire network of hospitals or clinic you're running. And depending on the time, we may get to see a little bit of that. But we are focusing very much on the administrative burden, which I'd like to show you in a moment. So I think the last slide here takes us into the world of how does a patient get to the care in the first place. So the first piece, effectively, is they would be looking to connect a GP. There could be a network of GPs who are providing an amount of services. In that particular case, the patient could be booking the appointment with the GP. If they get to the GP could be making that referral. The hospital offers you an appointment, or they offer you a number of slots that it could be available to you to allow you to go and book your appointment to attend. When you attend, in that little box in the middle, that is internal patient administration systems and EMRs, which we would interface with on a two-way basis and do in quite a lot of systems today. Ultimately, then is a decision to be taken as to how that's going to work. So if I go now, I believe, to the demo piece and I go and share, just let me set this out for you nicely. Okay. So if I go share my screen, one of my colleagues can tell me, am I actually displaying a workflow? Yes. So in our workflow, essentially, we have role-based access to systems. And what I'm showing you is a configurable workflow to go and manage both triage, pre-triage and triage, or to start the system at an active stage. If I really needed to put in before I actually allocate somebody to an appointment, a validation, a financial validation stage, or a safety stage, I can do that. We have one of those type stages. If I don't have enough information and I don't have enough detail to allocate the patient and need more information, I can move them from this particular work list to a letter sent, meaning I'm awaiting on some information from you. What we're doing here is an oncology solution, and I think it best represents how we begin to take fiddling around with spreadsheets and having to change lots and lots of dates in a diary to manage one particular issue that happens in oncology departments. And that particular piece happens when you're scheduling, and you're scheduling people to a bed. So here's my scheduler. In the scheduler, we're showing a hint here that we're also connecting to the pharmacy and the pharmacy's capacity to compound an infusion. And what I'm going to do is I'm going to create an appointment for Tuesday, the 31st of October. No, I'm not going to do it for tomorrow because there won't be room in this one for some of these appointments. All I'm looking to do is I pick a bed. And when I pick a bed, I would look to pick a name from one of my patients who's on the waiting list. Surprise, surprise, it's Dylan. If I just shrink that for the moment and I search for Dylan, and I've got a number of Dylans I'm looking for. I'm not looking for myself, thank goodness. I'm going to select this particular patient and I'm presented with a modal. This is information that's sitting on my waiting list, and all I'm simply doing is I'm going to allocate this patient to a particular appointment reason. In this case, it's FOLFIRI because it's colorectal cancer, and I've picked it from the details that I've just looked at. And in this particular instance, I'm going to define the number of occurrences and how often that's going to be. So in this particular case, for the number of cycles that have been defined by my consultant, I'm going to do this out now to the first week of, or the fourth week of January. And if I save this for my oncology day ward, I'm presented with a care pathway that's been generated from all of the available dates, and it's against a standard layout for the kind of treatment that I'm going to be giving to a patient and the kind of activities that are going to arise during the cycle of all of these pieces. And this is going to go down to the numbers of cycles that we had agreed to set out for the demonstration. If I find I've overshot the runway, I can simply cancel one of my steps because it's gone further than I'd intended to. If I go and create the care pathway, what it's gone and done now, it's gone and created, or it goes off to find the individual dates to create possibly as many as 30 or 40 different appointments at times that suit. Of course, I am now, I'm having a network possibly. Yeah, there we go. So I've now created this particular patient for a whole series of appointments in the future. One of the things it's done for me, it's gone and created the permanent treatment plan that I can now share with the patient on the day of the appointment so they can get a view, if you're seeing that particular screen, of all of the appointments and all the plan that's going to take me out into the early part of next year, rather than turning up from one appointment reason to the next. So in this particular approach, I also have the ability to stall this care pathway because the patient is too sick. And this is where a huge amount of work is changed. So I can go and select the period of time that this needs to be changed for. If it's going to be 1 week, then I'm going to see that the dates will actually change for all of my appointments. And I simply confirm the changes. And it recalibrates all of the dates out in the future. So I don't need any nursing staff going to redo all of these appointments every time there's a stall in the pathway. It will keep obviously the date and time for, or the cycle number in sync with the cycle number that we wanted to have. The fact that I've now pushed all of these appointments out to a different date is simply going to carry my pathway on to the time, such time that the patient is better. I'm possibly going to run out of time on this one, but what we are looking desperately to do is to avoid phone calls to the hospital. In one of the sites we did, within a month, the number of phone calls to the hospital was down by 1,000 a day. In one of the other hospitals that we provided our solution to specifically for oncology, they had the horrible meeting every Thursday for 4 hours for 10 people, all arguing as to what problems happened to the pharmacy because there were too many bookings put in and they were in breach of their capability of actual compounding the infusion. It would also be involved in the elimination of paper. Everything was going to sit on an electronic file. Any data capture we have would be integrated with your EMR. So again, all we're doing here is we're bringing the hospital outside the four walls of your hospital, reaching out to the patient and getting the patient to fill out electronic forms ever before they turn up for the hospital. In the oncology case, we're stripping out massive amounts of effort. If I have the time, Margarita, what I might just have a little look at is the University Hospital. And this is where, this is a live site. You could go onto this site yourselves. And all I'm going to do here is I'm going to click to get into the system. You get this really big button sitting in the middle of your website. You get an indication of the map and you say, I need to book a phlebotomy appointment. What type of appointment do you wish to book? And I'd say it's going to be an adult blood. Where do you want to get this? And you will get a map that says, here's the areas around Coventry that we are looking to provide the services through. We reduced the footfall in the hospital by 6,000 patients calling per month with the implementation of this system. The network has got bigger. We're providing it in the community. And all you do is pick the hospital that's closest to you and you click on it and it'll tell you when the next appointment is going to be. It's for your blood test. You indicated that earlier, but you may have indicated it for not necessarily for yourself. You could be booking it for your parents or for your children. Wednesday in the afternoon works fine for me. If I pick a slot, I have now reserved the slot at 15:45 or 3:45 in normal time. If I log into this, I can register for it, or if I do this and log into the system, it's going to take me to a bookings page. This is all branded on behalf of the client, whatever the client is. This is an NHS client. And we can indicate to the people running the clinic if I have any problems with sight or hearing. If it's a big clinic, they may be looking to put something up on a screen, and I can agree to the terms and conditions of the hospital. And if I simply confirm that, that is now, sorry, I didn't select whether it was me or my family. It's for me. So if I go and, sorry, I didn't do that properly. There we go. So if I go and select that, I confirm the appointment. That has now done a number of things for me. It's given me access to my patient portal, telling me I have an appointment, which I will be cancelling shortly, since I'm not taking up a slot that I have no intention of going to in the UK. But I've also sent a note to the patient. I've sent a note to their mobile phone. And if there was pre-op attendance or guidance on what might be happening at a particular clinic, whether it was ophthalmology or audiology, I would get that detail. I've also built the work list in the calendar for that date. Now that's taking out a lot of administrative effort from the system. And again, from a reporting point of view, all automated. If there are any questions at this point, I'll happily take a question. Otherwise, I don't want to hog too much time on this morning's session. I will open it up back to Marguerite.
Yeah, and that's actually a good point, Noel. Thank you very much. There is a chat available for anybody who has questions as we go along. Feel free to enter any questions into that chat in the meeting, and we'd be happy to address those at the end. So what I would say is, what does this mean to Mary? Noel actually brought up some of these on his own about those phone calls, 1,000 less patient appointment calls a day in one of these hospital systems. That's great. One of the things that I took away from it as an oncology nurse for many years, I would have to individually book all of my patients' appointments. It would probably take 20 minutes at the end of an appointment when somebody just wants to go home. So to be able to just pick the regimen that they're getting, the number of cycles, and have it auto-populate those appointments. And of course, you can tweak them and move them if needed, but that decreases a significant amount of administrative time. The other thing that is pointed out is that if you have multiple locations, this is a great way to kind of balance load those locations so you're not overstraining one of the locations that you have. And then also that instant communication and reminders to make sure people come in, because the last thing we want is to have people no show, because that really kind of puts us at a loss for our day. So we're going to move on now to Felix and our ECM tool.
Yeah, absolutely. Thank you so much, Jennifer. Appreciate it. So yeah, Dedalus ECM tool, what do? We centralize all different types of data objects, regardless of their type and regardless of their source. So in a hospital, there's coming a lot of data in immediate speed, and we all trying to capture that and centralize it. Data can come from an EHR, data can come from a paper record that the patient is bringing inside a hospital, clinical systems, a lot of different kinds, or administrative systems. We, with our Dedalus ECM, decided to not draw a line about, like I mentioned, the type and where it's coming from. Are we talking about DICOM images? Are we talking about TIFF, PDFs, JPEGs, videos even, or MP3 formats? Slide. Perfect, fantastic. So technically, we're uniting the entire ecosystem in terms of sharing data, centralizing data, making it available. There's a stacks of use cases when it comes to that point. Paperless data, for example, everybody's trying to reduce the amount of paper. So when you centralize all different kind of data objects, you of course scan them, you index them. You're trying to structure the unstructured data from all those objects and then make them available for all the stakeholders inside an ecosystem. Also, I mean, we're dealing with patient data, so legal archiving is a huge piece. Once you have all those objects digitalized, you can then trace and track what is being changed on those documents inside the central repository. So we are having audit trails embedded. The entire application is being traced, like who logged in, who made an annotation, all that kind of stuff beforehand, before it's being sent to other stakeholders like pharmacies, physicians, other clinics. EVNA is a huge topic right now in generally the healthcare market. Hide Media, for example, like I mentioned, can import DICOM images. That's a huge differentiator between other ECM solutions and Hide Media, that we can import those images and then relink them back to the EMR that the clinician is using. Because our main goal is to seamlessly integrate us into the already existing workflows of the hospital, so that for the clinician, not really that much is changing in the daily work, except the quality of the data that he's receiving, the quality of the documents, and the completeness of the entire patient folder. A couple of other use cases are you can use Hide Media as a migration tool. So if one hospital is switching from one EMR to another, and you already have all the data inside Hide Media, you can just relink this data, those documents, to the new EMR in immediate speed. We are having workflows like contract workflows, invoice workflows to assure that all the data that is inside those documents, contract, is being tracked, being indexed correctly, or automatically is being read by NLP or other engines. Also, in terms of revenue cycle management, once you have all different types of documents at one place, you can send a complete patient folder, patient file, to the revenue cycle management tool that you're using inside a hospital from Hide Media. And right now, I think I would just want to jump right into the demo and show you how Hide Media is looking like. So I'm just going to share my screen. All right, I hope everybody can see the demo screen right now. Perfect, fantastic. So yeah, we are having our nurse, Mary, and she's treating right now a patient called Laura Mickelson. How we can see down here, Laura Mickelson was admitted to the hospital twice. So we're having 2 cases. How would a clinician work inside Hide Media? We are having different types of views. We're having the cumulative view, the case view, and the document type view. The cumulative view is giving the clinician an overall view, 360-degree view of the patient. So you can see DICOM images, videos, PDFs, all kind of documents that are being connected to Laura Mickelson. You can have, yes, exactly, the cumulative view. So a whole 360-degree view of the patient. The case view that I was just in is showing, of course, the documents that are just connected to one specific case. So in this case, we're just having a letter, for example, or in the bigger case that she was staying long in the hospital, we have all different types of documents that we can retrieve and look at. If a nurse or a clinician is working inside Hide Media, he has numerous different options. Like I mentioned before, ideally, he's working inside the EMR, of course. But if we imagine there's a downtime period and the EMR is not available, we are having the great opportunity to work inside Hide Media and keep the business running, because you can easily compare different types of documents. You can easily compare different types of documents. For example, one radiology document here, and you can compare it with another document, and then make annotations. Say, okay, dear patient, we need to focus today on this specific piece inside the document. You can save it, of course, because you just changed something on the document, and then move forward with the treatment of the patient. Once Laura Mickelson is, let's say, discharged and we're done treating her, well, the question comes up: how do we share all the data? We can easily automatically connect us to a patient portal now. That's the next step of our document sharing, or we can manually say, okay, Laura, you want access to all the documents with the case that you just stayed at our hospital. You can just export all those documents that are connected to the case. So yeah, what makes us different between other ECM solutions? Having an overall view of all the documents is crucially important to being able to structure the unstructured data and making it available for applications that are analyzing. Because in most of the time, we're having applications or like one EMR that can import certain document types, and other document types, it's a little more difficult. So having one central repository like Hide Media for medical documents, HR documents, and even invoices is giving the opportunity to just connect with one connector to one specific application and then share it wherever you want to share it to. I would say that was it for the 10 minutes. I don't want to speak too long. There's a lot more better and as good stuff coming. I wouldn't say better. And yeah, I'm really excited to hear from the other applications. Thank you so much, everybody.
Thank you, Felix. So what does this mean to Mary, the clinician? One of the things that I love is that it gives me a 360-degree view of my patient, because without that, I'm not able to make certain decisions. So by being able to see all of the data from all the different areas coming into my EMR, so it's in my workflow, I'm able to make much more confident clinical decisions for my patients. One of the other things on this slide that I really love is what it talks about is 22 and a half more days saved that I can use taking care of my patients instead of searching for documents. How many times as a clinician are you calling a radiology facility trying to track down something from a specialist? If you have this system where they're all coming in to your EMR and you can look at them, you can make much more confident clinical decisions. So we're now moving on to our Trials for Care tool, which I will be talking about. As I might have mentioned, I am a clinical research oncology nurse, so this is a big love of mine. This tool is what made me want to join Dedalus. What this tool does is it helps match patients to clinical trials. And some of the statistics that are important to know is about 50% of clinical trials are under-enrolled in the United States. And we're talking 1 in 2 in men and 1 in 3 women in the United States per year experience cancer. So being able to get drugs to market faster only happens when we can properly enroll clinical trials. So 10% of clinical trials get 0 patients. So those just go nowhere. They stop right where they are. And a personal anecdote about this is, you know, unless you can have enough patients, it slows that research down. You then have to go back to the FDA. You have to file an amendment, which costs tens of thousands of dollars and a lot of time. And sometimes patients are talking about a little bit of time. In December, late December of 2017, a medication was approved for stage 3 melanoma. 6 months later, I developed stage 3 melanoma, and only because that clinical trial was completed in time did I have access to that. So just kind of bringing that home to a little personal side to let you know what that kind of means to the average person. And we'll talk about what that means to the clinician too. So I'm going to go ahead and share my screen, and I'm going to show you what we're talking about. So I'm going to wear 3 hats in this demonstration because our clinical matching tool can be used by pharma, can be used by clinical researchers themselves, and then the hospital systems. So in this system at the moment, I'm wearing the hat of the researcher. So I want to put together a clinical trial, whether I'm a pharmaceutical company, whether I'm a research physician, this is where I can do that. What you can see here is the amount of data in each of these sections. So I have over 1 million de-identified records that I am able to search through. And then we break it down, how many we have in condition analytics, observations, medications, and procedures. And this is Dedalus data that we have over, over millions of documents of de-identified data that people can use. So our goal here is to build this same sort of numbers in North America to join with the European and outside of Europe data that we have. And how does this work? So I'm the researcher or I'm the pharma, and what I need to do is to build a research protocol. So in that, I know that I will have inclusion and exclusion criteria. So I'm going to click on the little query builder button here, and this is where I would enter the inclusion and exclusion criteria. So we want to include something. What do we want to include? Let's say we want to include a condition, and that condition is Alzheimer's. So I'm going to click on this little launch query button here on the right, and that's going to tell me how many patient records I have that just meet that inclusion of just a patient with Alzheimer's. Now we can dig much deeper. We can put in age ranges. We can put in age of onset, how many years back we want to look at data. And then let's add in exclusion, so something we don't want to show up. And I'll take something very simple. I'll take a medication and we'll add aspirin. And again, I'll hit the launch query, and we'll see still, including this inclusion and this exclusion, we have 439 candidates in this database. So it also goes to tell you where these are, what sites they're from, what countries they're from, their age range, gender. And then what I want to do is save this. This is a research protocol I want to do. So I'm going to name it. And then the next thing that I have to do is send it for approval. So every research facility has an IRB, an internal review board. It has to be approved before we can send out those expressions of interest. So I'm going to send it for approval. And the other thing that I want to speak to here is you can then put in more information. What's the time frame of this study going to be? What's the purpose? Because these expressions of interest are going to go to your hospital. And that's where I'm going to show you that the third step is when that gets to you, that's maybe the clinical research nurse, or that's your physicians who then look at these and say, you know, we've got patients here that qualify for these research protocols. What does that do? Well, what it does for my patients, it gives them access to the clinical trials, which is incredible. And the other thing it does is it brings money into my facility. Pharmaceutical companies pay a great deal of money to facilities that have patients that will meet their criteria. We're talking tens of thousands of dollars. So, you know, that's great. So I'm just going to put in some, just because we don't have a lot of time, I'm just going to kind of fill these in to send this off. And then this can go off to that administrative person. And I'm not going to go through that step just in the interest of time, but that would just be me sending it to that review board. So you can see that it was sent for approval and kind of track it through the system. So the next hat I'm going to wear, and the final hat that I'll wear in this demo, is the hat of that clinical research nurse or that oncology physician or internal medicine physician who gets an email notification that says, you've got patients in your facility that could qualify for a study that could help save their lives. And in addition to that, there is financial compensation for you to be able to do that. Now, the researcher on the other side could not see any of the patient data. It's all de-identified on that side. But when it comes to me, I'm then able to see what patients are, you know, that would fit the protocol. And we'll take one of these and we'll just hit explore. And you can see all that information that I could have typed in to let you know what's in it for the patient. What kind of time frame it's going to take for the patient. You can see here that this expression of interest, we then accepted it. And then we can go through this whole workflow up here at the top that gets us to where we'd inform the patient. So here's where I can now see the patients. And, you know, I then can decide, you know, is this patient suitable? And I can take that opportunity to reach out to them, to tell them about the study. And then we can get that to the end where, say we had, in this case, we had 2 people, but say we had 10 people, we can kind of look at a little information as to how many times we contacted them. We've reached out by phone, we've reached out by email, any concerns the patient has. One of the things that's in this workflow here is the researcher the information. So if a patient has a concern, I can reach out to that researcher and ask a question as needed before that match is made between the patient and the pharmaceutical company. So that was a very quick demonstration of this tool. And, you know, as I said, very few people are ever even offered a clinical trial. So if we can start to increase the ability of people to have access to clinical trials, it's going to be able to speed those through the FDA approval process to be able to get more patients matched. So what does it mean for Mary? Well, it depends on what hat I'm wearing. If I'm Mary, the actual researcher, then what that does for me is it helps me find people out in this vast de-identified database of who would qualify. I can tell you, I used to have to scour paper charts, and it would take hours to scour paper charts to find people who met the inclusion and exclusion criteria. Taking away that amount of hours that I can then spend giving patient care is huge. So it's all about, you know, clinician satisfaction and being able to improve our workflows and allow us to spend the time caring for the patients. So again, quickly curate the cohorts that I'm going to need. And then, so marry the provider in a hospital system. What does it mean? So this means that your hospital system can bring in money from the pharmaceutical companies. That can then be shared with that clinician. That again can improve clinician satisfaction. We can decrease the enrollment time by 25%. And in addition, the more of these you offer and the more patients you have that would qualify, you are able to attract more research funding and grants. So yes, it's wonderful from a clinical standpoint to be able to offer this to patients to better their health, but it also helps to bring money into your organization. When you're working with very slim margins, that can be very helpful also. Next, we're going to talk about our command center, and I'm going to turn it over to Kevin. Okay, it's possible that Kevin is having technical issues. So let's hope we can get him back. I don't have that demo system up right now, but until we get him back, let me tell you a little bit about our command center. And Kevin, when you return, just shout out. So I think you're back. Kevin, are you back?
Yeah, I'm back.
Okay, great.
So happy to kick this off. We'll see if I can get my demo back through Teams, but right now I'm on my phone. So hopefully you can hear me okay. Sorry about the glitch, but the command center is a completely different, our fourth product, completely different product that we wanted to showcase today. And our question here of what would you put on your video wall? Many of our implementations are actually a physical command center. This is like a mission control. If you think of sort of the NASA type mission control room, or what the financial services industry has is sort of the Bloomberg terminals with tickers and real-time data. What we put in our video wall in most of our implementations is real-time KPIs and alerts. And these are in 3 different domains. So the perioperative, which is very much focused on optimizing surgery and operating rooms, and how do you optimize the schedule, reduce cancellations, same-day cancellations, how do you reduce those and optimize your schedule. So that's one important use case, is the perioperative or surgery. A second type of video wall that we often run in command centers are inpatient KPIs. That includes things like optimizing and reducing length of stay. It includes predictions for estimated discharge dates. It includes all sorts of hospital-acquired infections and how do you reduce those. So those are typical types of KPIs that we put on our command center wall for inpatient. And then the third big area is the emergency department. So that deals with KPIs for turnaround time and how do you optimize the patient flow from the emergency department, either to basically discharge and sending them home, or possibly admitting them into inpatient. Of course, these modules then work together, and you can see those KPIs and flows between emergency departments to inpatient or to other perioperative types of operating rooms. So those are 3 common use cases that we have on our video wall. It does not have to be a physical command center, but that's certainly one way to visualize it. So if you would advance the screen to the next. So this is an example of what this looks like. This is a real customer. The numbers and all the boards there, right? You see sort of it's many panels of this dashboard, and on the back large video wall that is sort of 3 feet high and over 20 feet long or wide. So a lot of different real estate to show many different panels, many different indicators. And then in front, you see some dual monitor types of workstations for those that want to act on alerts. And if they notice that something needs to be actioned, they then go in and resolve alerts or notify and escalate to others. Okay, so then our next screen.
And Kevin, I've opened up the demo site on my computer. If you want me to show it and you can speak to it, would that be helpful?
Yeah, let's do that, because I think that'll
Okay.
keep our handoffs minimized.
I'm gonna act as your
Great.
your
So
van.
if you start on the video wall 1 of 2, and we'll just give the participants here a little bit of, so this is the perioperative use case. So we are looking at surgery room. So in the bottom left corner, you see what is essentially a day. So this is going to be 12 operating rooms that sort of roll through. The right-hand side is going to be revolving, and you'll see 4 surgical specialties spread across 12 different operating rooms. And then you see essentially what is a surgical day. So this is running essentially from 8 a.m. to 8 p.m. There's going to be, right, a flow of patients that were planned or routine surgeries moving from left to right. And then some of those, right, we're tracking in the morning for surgery delays. We're tracking what were the hours planned versus what are the actual hours in there. And maybe, Jen, if you also go into Metroline, just so we can see a little bit. I know there's, right, this is optimized to see on a large screen. So it's, you know, we'd love to give you guys a more complete demo of this when you can see all of it. But just to give you a little feel for what type of information is out there, right? It's over 100 surgeries essentially that need to be done over the course of this 8 a.m. to 8 p.m. And all of these views are showing delays that could be delays of first surgeries in the morning. It could be how those first morning delays impact other things throughout the day. This is what we often call a metro line. This is showing on the left-hand side, right? There's, if I zoom in, you've got 113 sort of planned or routine surgeries for the day, and 11 emergency surgeries that have to be squeezed in. And then these will flow from left to right throughout the day. And all of the command center is running with real-time data, right? So this is going to change by the minute, sometimes by the second, as patients move through the day. Move through operating rooms throughout the day. You'll see different highlighted items. So the yellow indicated boxes with alerts, with various delays that could be a surgery that started late, or maybe it's a surgery that started on time, but it is ending late. And then various views showing, right, how do you optimize the schedule then? What do you do with the next schedule? Do you just kind of stack those cumulative delays up and everything gets delayed, or do you suspend a surgery and move it, you know, back to the end of the day? So there is a lot of optimization and improvements for all types of clinicians, nurses, surgeons, all the porters, people that need to clean rooms, and to move people between the rooms. So a lot of staff optimization that can be handled with this. And so this demo is really just the perioperative, but we have, you know, as I mentioned before, the command center covers over 170 KPIs from including perioperative use cases, those inpatient use cases, emergency department use cases, all of them running with real-time and predictive data. So that gives you a little feel for it. And just because I know we want to save some time from questions, Jen, I'll turn back to you. Thanks for showing some of those screens. And if you could highlight a little of the value for our Mary persona.
Absolutely. So, you know, when we talked about this, we were talking about the, you know, the clinician burnout. And some people might say, well, what's the operations help with that? Well, the operations helps with that quite a bit. Any way you can improve the operations in the healthcare system, you're in turn increasing the ability for your staff to be able to work more with their patients as opposed to working on operational needs. So what we've seen is a 20% reduction in nursing overtime. what we are seeing is, real insight, real-time insight into staffing, into emergency room predictions. And what this allows for is then you to improve your staffing ratios. And the tool is constantly learning as it's getting more and more data. So it improves the clinical processes and patient flow, immediate and measurable operational efficiencies, like a 20% improvement in OR utilization. So one of the biggest places to bleed money in a hospital system is the operating room when they're empty. So what we've shown in one of our large hospitals in Spain is that we can improve that efficiency quite a bit. One of the things that I would add to all of this is someone might say, well, how are you getting all of this data? So how we do that is that's using our interoperability platform that sits below any of our tools. So if you wanted to start with trials for care and you were really interested in that, we would then incorporate our interoperability platform, do all the connections with your institution, and then you'd have all of that data flowing into our trials for care tool. If you decided you wanted to expand to Command Center or any of our other tools in our toolbox, you'd already have all those connections made. So all we would have to do is then add that on. So it would be a much easier process. And that's why we speak of ourselves as a platform and a solution, and as opposed to a product, because we are a platform and a solution of different products, but they're all connected with that interoperability platform below. We'd really like to thank everybody. We do have a poll question that we'd like to ask, which I think will pop up on the screen, but it's really asking, from what you've seen, it's in the chat right now, out of the toolkit solution, which would you be most useful for your organization, would you say? So if anybody could click on that, we'd very much appreciate the feedback. I'm going to give you kind of a minute to do that. And also, if anybody has any questions, please please enter those for us. All right, I've seen you guys, your responses to the poll, and I really appreciate that. We'd love to talk more about those tools in the future, so we're here to do that if anybody would like to follow up on those tools to give you a much deeper dive. Does anybody else have anything they want to add as a last minute from my team?
Just one of the things that comes to mind that maybe should be pointed out, if this was easy to do, all those kind of problems would be solved, and the burnout for our clinicians would have been addressed. And it can't be addressed because the demand just continues to get higher. And it isn't very obvious where you might pick the very specific thing that's going to save all of this stress, all of this burnout activity. It's going to be a combination of a number of things, and sometimes those things can be relatively small. We talked about the reduction in telephone calls. If you get to a stage where you're looking to ensure that your clinic is going to be fully attended, very often people man the phone, they go ringing people, and that starts that piece going. One of the small facilities that we provide is that we get the patient to confirm they're going to turn up, and they do that online, changing the color coding of the work list so that when you need to go and look and see who do I need to ring, you've automatically reduced the risk or reduced the list. What that effectively does is if you take that type of thinking to many different actions that go on both at an administrative level and at the clinic's involvement, then all of these opportunities arise to go and reduce that burden. There's obviously a lot of solutions that we're presenting here today, and they follow very much in that same footstep. And Kevin's overarching presentation highlights just exactly how easy it can be to get all the information you need in the one place.
Excellent. We really appreciate everybody's time, and we're always here for follow-up. And again, thank you very much. We'll give you some time back because again, we're presenting on efficiency here and decreasing your burnout too by giving you a couple minutes to do something for yourselves. So enjoy the rest of your day and cheers.
Thank you so much, everybody.
Thanks, folks. All the best.